But whose faces are you going to see today? Well, mine, and I've introduced myself. You're going to see Tim. And the third of our colleagues you're going to see is Helen. So Helen is our National Account Manager, and Helen is in daily contact with people in primary care. So I'm sure she may have some burning questions to share with us all that she's been asked during those contacts with people in primary care. Just some domestics in terms of how the session's going to run. Well, please just sit back and enjoy the session. Participate if you can. There's no need to take any notes because we'll follow up the session in a day or so's time with an executive summary of what it's covered. And also, we'll answer some of those questions that maybe we haven't had time to touch on in the 45 minutes time slot. As I say, when we get to the Q&A, it's going to be really, really simple. Either just put your contribution into the chat or raise your virtual hand, and we'll try and make sure we include you and spot you and include you. Right, so in summary, on screen is what the rest of the webinar is going to look like. And now probably all that remains for me to do is pass the presenter's baton over to Tim. So over to you, Tim.
Thank you, Jerry. All right, I shall just share my screen with the slides. So hopefully you can all see these slides. So I've got 20 minutes to talk about the new contractual needs on first patient contact assessment. In this time, I'll look to cover kind of 4 key areas before we move into the 20-minute facilitated session. So part 1, as you see on screen, is about discussing the need, defining the need. The next session will be around considering possible solutions, then managing patient expectations, and finishing up on resources, training and support that's available. I've got 20 minutes, so in that time, clearly got a reasonable amount of content to cover. We'll go through at a sort of moderate pace, but hopefully sharing a reasonable amount of detail so we all get something from this that we can then pick up in the Q&A and engagement sessions when we get to it. So in terms of defining the need, well, I'm sure it's not lost on any of us working in primary care. I've been in general practice now for over 20 years and it really has never been tougher, has it? We're hit from all angles. Here are some snippets from our beloved media, so the Daily Mail, the Sun, the Mirror. I personally can't bear to pick up any of these papers, but here are the headlines that we're faced with, and the whole new contract and the access targets are really generating some unhelpful headlines at the moment, and the whole 8 AM appointment scramble is a particular area of focus, and it is compounding fairly significant system pressures on practices. It's not escaped any of us that we're emerging from a really challenging period, having been through a COVID pandemic. Most of our acute trusts are suffering significant delays to outpatient appointments. Emergency departments, the ambulance service are all under significant pressure, all of which have an impact on primary care access. So here we are trying to improve our access services, trying to avoid asking patients to call back at 8 AM with fairly significant compounding pressures, not to mention all of our workforce challenges that affect our capacity. In terms of defining the need, this is taking a bit of a look at our kind of key contractual areas that define the needs. So most colleagues on the call will be aware of the updated 2023 GMS contract, and the first bullet point there is the kind of key quotes that each GP contract, the contract is updated to make it clear that patients should be offered an assessment of need or signposted to an appropriate service at first contact with patients. It doesn't actually explicitly say you shouldn't tell patients to call back at 8 AM. That's implicit in that statement. And I guess slight glimmer of hope within that is it doesn't say anywhere that we need to offer every patient that calls our practice at any hour of the day an appointment with one of our doctors. It is about an assessment of their need and then appropriate signposting and considering the services that are available to your patient population. On the horizon, we've got prospective record access from the end of October. So this is NHS app access, patient access to records we need to consider, along with the mandatory use of cloud-based telephony. And then there's the QoF QI 37 points focused on access. We've then got the update to the 2023 PCN DES. So there's the Impact Investment Fund that from last year to this has been reduced from 36 indicators down to 5, with 2 focused on flu, 1 on LD checks, early cancer diagnosis around the fit testing and lower GI, and then a 2-week access indicator. And the 2-week access indicator adds another kind of dimension to these access targets, doesn't it? Because there's a requirement that 95% of patients are booked into an appointment within 2 weeks. As most colleagues on this call hopefully know, there's a national slot type category, planned care, that kind of absolves you of that indicator. So the trick is where you've got nurse appointments or some GP follow-ups where appropriate that are going to be booked in excess of 2 weeks. If you use the planned care national slot type category, it's invisible to that indicator. So that's the main way many practices are tackling that particular challenge. And then we've got the access target, and this is essentially recycled impact investment fund monies. 70% paid upon agreement to participate, which is paid in 12 equal instalments, i.e. monthly, straight into your lead practice, your PCN, and then the remaining 30% paid at the end of the year against an agreed access improvement plan with your local ICB. And then finally, there's the NHSE capacity payment, and this is actually a payment that was news to me. I don't know how many of you attended the NHSE access webinar a couple of weeks ago. There's talk of a single capacity payment, and the kind of quote from NHS England is it's to fund transition cover to clear appointment books ahead of rollout of a new model of care. And interestingly, it's worth quite a significant sum, so £13,500 per practice. And when I posed a question on that webinar, it seems that's regardless of list size. So whether you're a 2,000 patient practice or a 20,000 patient practice, there's £13,500 available. And the NHS England Access webinar series explains to provide more information on that in due course. So fairly vague information, but a fairly significant sum of funding. And then just to bring some to life in terms of numbers, these numbers you see on the screen are based on what NHS England define as a UK average list, which is these days defined as 9,639 patients. So it's up on previous years. And you can see that all of those kind of 4 pots combined, it's worth just under 50 grand to a UK average list of practices. It's an amount that one can't ignore. Most of it is made up of those 2 IAF access payments, with the rest from the 2-week appointment target and then those 37 QOF QI points allocated to access. So moving into considering some possible solutions. So I've just got 4 slides to start to kind of help us gather some thoughts about how we might tackle this, bringing in some experience and learning from previous work around access, but also some of the presentations I've received from NHS England and the access webinars. And I think the most important component when we're considering possible solutions is clearly not just, I was about to say the practice team, but actually, of course, we've got the wider team now, haven't we, supporting the practice from the PCNR additional roles. If we think about the front line, if you like, of our practices, staff are absolutely essential to success. You know, they are the gatekeepers, some refer to them as Rottweilers, to the surgery. And, you know, we need to really make sure we get the best out of the team. And I think our front line reception staff these days, often being renamed as care coordinators, have a particularly important role in this, and supporting them with scripting and training is really going to be essential. So advice really is we engage staff early, help them to understand the contractual changes, help them to understand and discuss the pressures on practice. They will often have a number of thoughts and ideas and potential solutions. Really empower your team with a kind of co-design approach. So work with them to help understand the pressures the practice is facing, consider workforce solutions, consider technological solutions. I made a suggestion of using tools like process mapping to bring changes to life. You know, how can we help staff visualize this sometimes? And one of my next slides kind of gives an example of a process map that's been shared. But how can we help our staff to see the process changes and you know, suggest new ways of doing things and improvements and adaptations. Practice staffing. So it may be appropriate to review staffing levels and particularly skill mix. At my practice, we've changed all staff working in our reception areas from receptionists to care coordinators. We've not just changed their title to care coordinators, we've updated their job description, and we've actually introduced a tiered rate of pay. So there's a 50 pence per hour incentive payment if they adhere to their training, and we listen back to calls and we check concordance. So there are different ways of sort of rewarding and encouraging and incentivizing your staff. Consider training needs, so care navigation training, perhaps conflict resolution training, because some of the changes, i.e. encouraging your staff to consider community pharmacy consultation services, may not be particularly popular with patients. So it may require negotiation skills and conflict resolution skills as patients express their dissatisfaction. Additional roles, reimbursement scheme staff, so these are staff from your primary care network. NHS England have introduced greater flexibility with the hours roles, including nurse ACPs now, so nurse practitioners, and increasing the cap. So you were in the past only allowed 1 ACP, typical size PCN is now allowed 3. Can they play a role in supporting access for practices? The impact investment fund targets have been reduced, as we've already talked about, to just 5 now, with a distinct focus on access. And it's really how we can make best use of the hours team to support access. A lot of the impact investment fund targets around SMRs and what have you have gone. So, is it now appropriate to consider redeploying members of your pharmacy team, for example, to support access? Can they help with meds queries? Can they help with medication reviews to essentially achieve release capacity within primary care to allow your GPs to focus on more acute access? Paramedics, advanced clinical practitioners, first contact physiotherapists can provide direct access and resource to support access. So that's a direct support. You then also got kind of indirect support. So what activity can a PCN take on that releases capacity and removes work from the practice team? So we talked about medication reviews and clinical pharmacists as an example, but you've also got social prescribers who can perhaps take patients with significant non-medical needs, with social needs away. You've got the mental health practitioners, but you've also got care coordinators that can perhaps help with some of the back end activity that can release capacity. I talked earlier about an example of a process map. Here's one that was shared by NHS England on a recent Access webinar, and you can hopefully see it's quite a good way of bringing it to life. We make significant use of standard operating procedures within my practice that support staff with scripts and with process. This is a nice visual way of laying out a new process, and you can see here the different forks in the road at different decision points. It's a really nice way to get it down on one page, and I find it's a really useful training tool, but also a really useful care design tool for practice staff. When also considering possible solutions, technology is a really important one. So we're all aware that it's going to become mandatory to have an IP telephony system. Many of the IP telephony systems, certainly the one that we use within my primary care network, have a range of functions that actually really do add value. So auto attendant functionality, that's the kind of push 1, 2, 3, 4 for various options. A lot of the modern IP telephony systems can have one of those options go direct to a text message, so you can kind of almost have workflows, if you like, within your phone system that negate the need to speak to a receptionist, that can text the patient information, perhaps self-referral information, perhaps links through to your online consultation system, be it eConsult or Accurex Triage. It allows smart routing of calls, both within your practice teams, but also as PCNs. You may be looking at setting up access hubs where you can take some telephony pressure off practices, perhaps to some teams of additional roles. So a pharmacy hub, for example, could take prescriptions queries. You can use on-hold messaging to essentially support the narrative to your patients in terms of use of CPCS services, the sowing the seed that they may be seen by additional roles and not just their usual GP who may be able to better support their care, etc. And then the Surgery Connect, the system that we use, for example, has a queue buster function, so you can set a threshold point. Usually when there's 5 or 6 in a queue, they push a button and they get a call back, which avoids some of the frustration when they're waiting on the system. Clinical systems, so EMIS system, one of the main kind of two in the country. There's suites of search and reports. Ardent have also supported with some of those, where you can essentially start to build a bank of intelligence where you understand the demand. You perhaps look at, is there variation between your GPs in terms of follow-up rates? Are there high intensity users that you'd want to identify and perhaps proactively direct to social prescribing services because they've clearly got significant unmet needs? So, you know, you can use your clinical systems to support your approach. You can use templates within your clinical systems to ensure consistent data entry. And what I mean is a kind of care navigation type template where each time your receptionist takes a call, they need to complete that template. And you can both use that to kind of guide the conversation of your reception staff, but it can also record the outcome of those encounters, both for audit purposes for NHS England, for demonstrating compliance against your ICB plan, and service iteration and development. Protocols, prompts, pop-ups to safety net and ensure consistency. So again, these are all different tools built within your clinical systems. Online consultation systems, I think they do offer a significant degree of potential, whichever solution you use. One of the key benefits of online consultation systems, as opposed to patients calling at 8 AM and getting straight to a receptionist, is they're asynchronous in nature. And what's meant by asynchronous is that you're not under that bit of duress with 30 in the queue and that mad 8 AM rush. It kind of slows down time, because as the online consultations come in, you usually make a promise to the patient to get back by the end of the next working day or similar. You allow yourself that breathing space to take a little more time dealing with that acute contact and directing it to more appropriate members of the team. So it kind of helps smooth demand, if you like, and it allows patients also more time to tell their story. Most of the frameworks used by these online consultation tools are around the ideas, concerns, expectations, where patients get the space and time to explain why they feel they need to see a GP, and therefore allowing the practice more time to direct their care more appropriately. What's really important is that all demand follows the same path. So, for example, you can't have the phone system directing a number of patients to online consultation systems, but then a patient getting a totally different experience. They're in receptionist, i.e. getting dropped straight into a doctor's appointment. Your reception staff really need to follow a fairly similar and consistent approach, so the patients aren't unwittingly trained to game the system. They understand whichever option they choose, they're going to have a very consistent approach from your practice. And then the final slide in terms of technology is data. There's a whole range of data available. In the top left-hand corner, that's a screenshot from Surgery Connect, which presents to you the call data. So that was my surgery on a Monday morning. There's 26 in the queue. It's fairly typical. It's that 8 AM rush. I think this picture was taken at kind of 8 minutes past 8 on a Monday morning. We don't really want to be having 26 in the queue. We need to get better at that through all of the solutions we've talked about. In terms of data, there's a range of sources. We've already talked about the data within your clinical systems. EMIS System 1, you've got Apex, which is Edenbridge linked with EMIS that will provide access data. You've got Ardent Manager. I'm sure there are other providers as well. Your IP telephony system, your online consultation system provider will also provide you with data, and there's some screenshots on the right hand side about typical data provided by your online consultations, where again you can start to use that to iterate and model future plans. I've talked at the bottom finally about use of data, so planning, visualization, monitoring, PDSAs. So PDSAs, plan, do, study, act. Again, it's an iteration of your service development as you learn from the data, and then to evaluate the impact of any changes that you've made with your staff. Managing patient expectations. You can imagine this is a really important one, because in terms of both involving patients in the design, but then managing patient expectations, their behaviour is going to have a fairly significant impact on the success of any approach to access. The first question is kind of how do we understand, how do we assess current patient experience and expectations of your practice to help in the shaping of your services? And I've given 5 examples there of sources of data. You've got the National Patient Survey. However unrepresentative we always find it, we for the last 5 or so years have been running a local patient survey where we've kind of taken a few of the exits of the National Patient Survey, but adding in practice-specific questions that are useful to us, recognising that the National Patient Survey really is fairly unrepresentative, and we found that very helpful. Your patient participation groups, and it may be an opportunity to revitalise them now, and perhaps try and find ways to ensure they're more representative. One of the ways very quickly we've used in my surgery is we ran a local patient survey, and we asked patients if they wish to get more involved and help shape services, and a bit of a kind of call to arms around the access conundrum. And we then use the 6 CQC population groups. So we asked the patient to identify themselves against a population group. And as those of you who are well versed with CQC know, you've got children and young adults, you've got patients who suffer of mental health, patients who suffer of long-term conditions, and you inherently then give yourself different kind of cohorts of patients that you can engage with and start to co-design services with, and that's a very CQC friendly. And you're doing that. So birds and stones, really. Friends and family test is an old favourite, and then if you wish to, perhaps when you got those population groups of patients who have identified themselves, consider some patient focus groups. So an hour or so of an afternoon, of an evening, with a focus group of patients to run through some of your process maps and ideas and sense check it and engender their support. A final point I'd make with the value of patient participation, patient groups, is if they endorse and support the change, they're very powerful advocates. And if you get any future complaints, a really potent foil I've found is both telling the patient who complains that it's a representative group of their peers who've helped shape the service, but also invite them to join the patient participation group and be part of the solution, not the problem. And I very rarely find they accept that kind of offer. So it's really quite a good diffuser of patient complaints. Ways in which we can consider managing patient expectations. So these are the kind of comms mechanisms available to you as a practice, your website. And perhaps at the moment, most of us got an appointments page. Perhaps consider rebranding that as an access page and getting a message across to your patients as a range of access options, not just simply booking an appointment with a doctor. So explaining the additional roles, explaining the CPCS service, self-care, NHS Treble 1. Most of us got a practice newsletter. That's an obvious source. You've got social media, Instagram, Twitter, Facebook, Instagram if you're really down with the kids. Notice boards, more so these days, TV screens in the waiting room, direct communication, so we can text our patients directly, email them. You can use the messages on your phone systems, and we mentioned PPGs. Within the access requirements, there's the ICBs, there's a 30% ICB plan, there's a requirement that you meet with your PPG and that they are part of that kind of co-design experience. So, you know, it is kind of part of the requirements in terms of developing your plan. A number of us have let PPGs wither on the vine over COVID. We've had lots and lots of pressures on us and more challenging things to focus upon. So, you know, it is actually a requirement of this, and certainly CQC do look to practices to have patient participation groups. I've already talked about considering identifying population groups from your PPG that align to the CQC population groups, and I really would encourage you to consider your patients as positive agents of change. If you can harness them and garner their support, they really can, you know, make quite an impact for you. And then, yeah, considerations: recruitment to PPG to ensure a representative group. Most PPGs are unrepresentative, aren't they? They're patients who are retired and have the time available to them. Sometimes you need to direct patients to the group, and you know, get your reception staff, your GPs, your nurses to direct patients to join the group, and those that might have most constructive contributions.
Hey, yeah, I don't think it.
Consider remote versus face-to-face. So you've got a range of options available to you. So you don't have to have all your PPG meetings face-to-face. You can hold them by Teams and Zoom and whatever we do at my surgery, and then yes, communication and engagement. So coming to the end now, resources, training and support available. So in terms of NHSE funded support offers, there's a range here listed, and again I strongly encourage you, if you haven't already, to sign up to the NHS England Access webinar series. That is the place where most of the resources and funding available are being shared and announced, and links. At the moment, the presentations I've been to, they're directing you back to your ICB, but you know, I think there's another half a dozen in this series, and NHS Futures is a place most of the webinars are listed, and certainly you can get the slides and recordings from previous ones. So there's recovering access to primary care webinars I've just mentioned. There's care navigation training, a virtual offer that is going to be made available in the future, details that haven't been released yet. There's fundamentals of change and improvement training, so that's essentially change management training that's going to be made available to practices. Digital training specifically for digital and transformation leads, and it's a 12-month training program, so that's for the hours funded digital transformation leads. General practice improvement program, general practice improvement leads, national primary care improvement communities. I think they're looking at setting up some kind of community that we can join, a bit of a forum, I guess. And I mentioned earlier, there's £13,500 payment to practice to clear appointment books ahead of the new model. Resources and support. If you haven't signed up yet to Future NHS, that is the place NHS England to put all of the webinars and then the slides and resources associated with it. Your local training hub, most often hosted by your federation, is a source of training and resource and support. And then PCN, practice funded training and development, so training that you identify yourselves that supports and meets your needs. So in terms of, this is a Thornfields training, I mentioned care navigation training. Certainly one of the critical determinants of success in my practice, we've been trying to tackle access, is our frontline staff. I mentioned earlier, we've changed our staff job titles and job descriptions from receptionists to care coordinators, and we really tried to adapt and deliver care navigation training and conflict resolution training. So Thornfields have got a couple of care navigation offers. There's an offer that is sort of 3 or 4 days long, and a new offer that is a half-day workshop, a bite-sized care navigation session, if you like. And I think it's very appropriate for me to bring in Helen at this juncture to talk a little more about that, as Helen leads on this. So I want to do it as a service.
I've just posted the link to the training page on our website about this. So a lot of you might have had active signpost and training from us before, but we realise that time is very precious in a practice and under extreme pressure. So we've created a simple bite-sized half-day workshop. So if anybody's interested, then you can contact me directly, look on the website, or book on an individual basis if you have stuff that you wanted to do. So that was just a quick mention of that. Back to you, Tim.
Right, thank you. And then my very final slide before we move into the open session, just to try and distill it right down. Most of us, when we attend these webinars, I throw in a load of information at you. We're going to send a summary out. The recording is going to be on YouTube, but just try and distill it right down in terms of perhaps 3 key takeaway messages from today. I think it is really important to review practice workflows and optimize resource utilization. So we talked about process mapping with the team, co-designing the new approach to access, considering all resources that are available to you as a practice. So encouraging patients to participate in self-care, perhaps using some of the NHS England resources related to that, the practice resources, CPCS, 111 walk-in centre, the services available through your additional roles reimbursement schemes, self-referral schemes that are available locally. NHS England funded on-site facilitator support is available. NHS England are directing you to speak to your ICB, but there are on-site facilitated sessions available to support you with that change funded by NHS England. The next one is around staff skills and training. Would really strongly encourage you to essentially conduct a training needs analysis, reflect on the skills that you currently have within your reception / care navigation team. It's really important they take a consistent approach however the patient attempts to access the practice, careful scripting management of the patient care pathways, and just building a framework of not just training and support, but also compliance, because I talked about there's 50 pence an hour tiering that we use at our practice, so there needs to be some teeth sometimes behind it in terms of if staff aren't adhering to training and consistent. The final one is technology, data and evaluation, using technology to support you to manage demand, support care pathways, using IP telephony, online consultations to try and smooth demand, spread workflows and move away from that 8 AM peak that burdens us all at the moment. And then utilising a range of data sources to support you evaluate and monitor, and it'll also be required for the ICB / NHS England reporting. Thank you. Over to Jerry for part 2.
Well, brilliant, Tim. I thought that was really helpful. And when I reflect back on when I was a practice manager, when these things were introduced, I always valued someone going through in real detail, step by step, what the requirement was and possibly what some solutions may be. But I also note in the chat that Anne's passed a comment around some of these plans. Majority of you don't know me, so one thing you need to know about me is I'm an Evertonian. And the thing about Everton is that on paper they're a fantastic football team, but unfortunately you play football on grass. And the same is kind of similar of some of the plans that come from the centre, in terms of they make sense on paper, but as Anne said, some of the solutions in terms of recruiting people with the appropriate skill set, people like that don't grow on trees, so those solutions aren't that easy to apply. So that was really informative too. So the second part is to open the floor to yourselves, and you can either ask questions by popping something in chat, or you can raise your virtual hand and we'll come to you, and then you can pose a question or just a comment or something, a bit of information, a bit of knowledge, a bit of understanding that you think might be worthwhile to the other sort of 70 odd people on the call. Whilst you're gathering your thoughts, I'm sure Helen, who speaks to, as I say, primary care people every day, may have some burning questions that she's been asked previously. So Helen, do you want to share something there?
Yeah, thanks, Jerry. When people were registering, we did have a lot of questions submitted. So some of them were very similar, and we probably aren't going to get a chance to answer them all today. But like we said, we are going to summarise all of that information and send that out to everybody after today. But one question that came about is there a target for the amount of online consults a practice is required to achieve?
Yeah, so if I pick that one up, there's a couple of, I guess, perspectives there. So there's a target around online appointments. So there's a GMS contractual target that 25% of appointments are available for online booking. There's not a specific percentage target for online consultations. It's a contractual requirement that a practice offers online consultations, but not a specific target in terms of numbers, rate per patient, percentage, etc.
Okay, thank you. And somebody else mentioned that they were really keen to learn and understand models that other practices have already put in place, if any, and what barriers they came up against, and was there any evidence of the patient satisfaction levels. So really, obviously, we would like to hear if anybody's already implemented anything in their practice and would like to chat now and mention anything that they came up across against, or anything that's been really successful. So if anybody wanted to chat, just please raise your hand or put your camera on.
Yeah, so feel free. I mean, don't be bashful. If you've got a good idea that is worthy of sharing, then now's the opportunity. We get lots of feedback from practice managers that they're always worried that maybe they're reinventing a wheel that's been invented somewhere else already. Okay, looks like everyone's equally stumped in terms of new ways forward.
Okay, well, while people might want to come forward, I'll just go and have a look through the other questions that we've got. Oh, here's one from Mandy. Online booking, would that include appointments being booked in via patches?
That's a difficult one, isn't it? Because it's how NHS England measure it. Most of the data measured by NHS England is through national slot type categories and reported by our clinical systems. So I know, for example, last year when we had the Impact Investment Fund target around use of online consultations, the system suppliers were reporting directly into NHS England for that target. Obviously, Patches is one of those providers. So I would have to check with NHS England on that one, because one would logically think it does, because so both Patches and also Accurix, of course, now has a direct book appointment, doesn't it? And that is effectively online booking. I just don't know whether their monitoring has caught up with that just yet.
Thanks, Tim. So Lucy has asked that she really like more info. How did you set up the skills analysis with the staff and set up the increase in salary?
Yeah, so one of the things Joe and I discussed was perhaps Thornfields sharing an exemplar template in terms of skills analysis and this sort of things. I think these sorts of resources will be useful to practices, and essentially a skills analysis is a simple template approach where you, as you can imagine, in column 1 have the names of all of your staff, and then a simple checklist against the desired skills for that role, and the training and the time in post and what have you. And then in terms of the increase in salary, we used our local employment law support firm to help us with that, because it did involve a contractual change. And essentially, when the advice we had when providing a targets was that, so we when we provided we implemented this from April of last year, actually April 2022. So we provided staff with a cost of living increase. We actually wanted to put into the contract that 50p tiering. The advice from our HR providers was not to do that, because it then becomes contractual and it's very difficult to unpick it. So what they helped us with was an addendum letter, if you like, to the contract. We put in 3 targets. So back last year, when we had the IIF targets, we put 1 target in around encouraging use of CPCS. So we provided a target to each care coordinator of the number of CPCS appointments they had to book each month. We put a target in around call handling. So basically, we set expectations in terms of the way calls were answered, and then we listened back to 5 calls each month and scored them against that, and they had to achieve a certain percentage to achieve that 50p tiering. And then the final one was around patient feedback. So we picked random patients that the receptionist had spoken to each month and sent a dozen of them a link, an accurate link to a patient survey. So it's based on patient feedback. So are you making it fairly difficult for the staff to game? They didn't know which patients we were going to choose, so they kind of had to be nice to all of them, just in case we picked that patient. That worked quite well. But yeah, the tip was you had to have it as an addendum to their contract. The advice was not to put it into their core contract, because it became very difficult to unpick it further down the line.
Just to follow up what you said there, Tim, about the template that we have. So we have it's basically an Excel spreadsheet, but it's all laid out for you, where you can enter all your staff and do an individual trainer needs analysis with them, if anybody would like that, or can send it, maybe Jerry, with the information that we'll send out to everybody. So somebody's asked, how do we apply for the 13k funding?
Yes, as Shaheen's asked that. I would like to know that as well, Shaheen. I'm waiting with bated breath to hear from NHS England. It was, if you go onto NHS Futures and download the slide pack from week before last, is a week last Wednesday, whatever date that was, you'll see a slide referencing this £13,500. There's no detail of how to get it yet, and it talks about phasing over a sort of 12 to 24 month period. So there's both no detail of exactly when we're going to get it and how we're going to get it, but it is there in black and white, and I've certainly downloaded those slides, so I plan to hold them to it for the future. It seems a very generous amount, and as I say, the only narrative they provided was it's to clear the appointment books. I did challenge, my practice is quite a large practice. I did feel it fairly unfair that a 2,000 patient practice got the same funding as a 20,000 patient practice. It seems a bit of a blunt tool, but yeah. So my recommendation would be to download the slides.
Okay. Can I just jump in there, because one commitment we did make was that we'd finish on time, so I'm conscious that we're about a minute away from the end, and I know time for some of you guys is really precious. So if it's okay, I'll kind of pull all the loose ends together, but I know that Tim, Helen and myself are quite happy to hang back after 1:15. So if people want to hang back, we can carry on this discussion, but I'll just pull together the kind of loose threads in terms of finishing the formal session. So as Tim alluded to, one of the key things to do when there's a change is to make an assessment of the skill set of your staff now versus the skill set they will need when they adopt the change, and we can help with that. And I'm just going to put on screen the kind of contact details for that, so bear with me 1 second. So hopefully what you're looking at on screen now is Helen's cheery face, accompanied by a QR code. So if you scan that, you'll be able to go to our contact page, and that will then enable you to drop us a line, ask us any questions that you've got about how to deal with this change. And if you want to continue this conversation, we're just very aware that sometimes being a practice manager can be quite an isolated activity. So we think there's an opportunity to have a focus group of primary care practitioners that we will get together once a quarter to kind of draw upon their kind of lived experience. I know presently AI or artificial intelligence gets a lot of airtime, but we're keener on RE, which is real experience. So if that sounds of interest to you, if you'd like to join a group of like-minded people, we'd meet once a quarter, we'd reflect on the quarter that's just gone and kind of do some horizon scanning about what the future can hold and what we can do to help with that future, then feel free just to contact me direct by scanning that code. I'll also put my email address into the chat, and then we can have a follow-on discussion about that. We've got a feedback form, so hopefully you've found 45 minutes with us of some value. It would be great to hear your thoughts. So again, if you can scan that, it'll take you to a feedback form. We'll also again put the link in chat if you can let us know how this was for you, and also any suggestions about future sessions. So we're at just past quarter past, so all remains for me to say is thanks for you that have spared the time and invested the time to join us today. Big thanks to Tim. I thought that was a really straightforward, and you really kind of unpicked a difficult topic in a way that I certainly now understand. Thanks to Helen for the questions she asked on other people's behalf, and one of our behind the scene colleagues, Jonathan, for really pulling all this content together. So thanks to everyone. And in the main, thanks to all the people who've attended, because you've invested some of your valuable time today. Hope you found it of use. And maybe we'll see you next time. So keep your eyes peeled for future free webinars from Thornfields or FPN. So look after yourself.